management of dyslipidemia and coronary artery disease forms an important part of management, overall comprehensive management of diabetes. Type 2 diabetes is associated with 2 to 4-fold increased risk of cardiovascular disease. Aggressive therapy of dyslipidemia will reduce the risk of cardiovascular events in patients with diabetes, and primary therapy should be directed first at lowering LDL levels. The insulin resistance in type 2 diabetes contributes to the dyslipidemia. So, screening for dyslipidemia happens at the time of diagnosis as well as during follow-up. So, obtain a lipid profile at the time of diagnosis of diabetes or at an initial medical evaluation. Every 5 years thereafter, if the patient is under 40 years of age, or more frequently if indicated. Before starting a therapy with statins or other lipid lowering therapy, lipid profile should be obtained, and it should be followed up 4 to 6 weeks after initiating therapy to decide on further change in the drug dosage. Annually thereafter, to help monitoring the response to therapy and to ensure compliance. The pattern of dyslipidemia seen in type 2 diabetes is elevated triglyceride levels, decreased HDL cholesterol levels. The mean concentration of LDL cholesterol in those with type 2 diabetes is not significantly different from those who do not have diabetes. However, the qualitative changes in LDL cholesterol may be present. In particular, patients with diabetes tend to have higher proportion of smaller and denser LDL particles, which are more susceptible to oxidation and may thereby increase the risk of future cardiovascular events. So, it is important to stratify the patients as high risk, borderline or low risk based on the cholesterol levels. With high risk category having an LDL cholesterol more than or equal to 130 milligram per deciliter, HDL cholesterol less than 40 milligram per deciliter, triglyceride levels of more than or equal to 400 milligram per deciliter. And it is also important to estimate the atherosclerotic cardiovascular risk before we could decide on the treatment and the target strategy. So, we have an online calculator for the ASCVD risk, which includes parameters such as age, sex, race, systolic diastolic BP, total cholesterol, HDL cholesterol, LDL cholesterol, history of diabetes, hypertension treatment, on statin therapy, on aspirin therapy, and smoking history. This will give us a 10-year mortality risk from ASCVD, atherosclerotic cardiovascular disease. Apart from ASCVD, we have specific LDL targets for drug therapy and lifestyle modification. In most of the cases, the targets for initiation and for goal is 100 milligram per deciliter for both lifestyle modification and diet therapy as well as drug therapy in patients with established coronary heart disease, peripheral vascular disease or chronic kidney disease. Those without atherosclerotic cardiovascular disease, we generally advise only lifestyle modification and diet up to a LDL level of 130, beyond which we advise drug therapy to lower LDL levels and to reach a target to less than 100 milligram per deciliter. So, lifestyle modification includes weight loss, reduction in saturated and trans fat intake. Fat should include less than 10% of total calorie intake. Increased intake of dietary omega-3 fatty acids, viscous fibers and plants, stanols and sterols intake. Increased physical activity and optimize glycemic control. So, as a preventive strategy for patients with type 2 diabetes who fall in the age group of 40 to 75 without an atherosclerotic cardiovascular disease or risk, we can use moderate intensity statin therapy in addition to the lifestyle modification. In patients in the same age group with a higher risk detected by ASCVD risk, it is reasonable to use high intensity statin therapy. For patients with diabetes aged 20 to 39 years with atherosclerotic cardiovascular disease risk factors, it may be reasonable to initiate moderate dose statin therapy in addition to lifestyle therapy. For any patient who is having diabetes and established cardiovascular disease, it is advised to use high intensity statin therapy along with lifestyle modification as a secondary preventive measure. So, high intensity statin therapy lowers the LDL cholesterol by more than 50%. Moderate intensity statin therapy lowers LDL cholesterol by 30 to 49%. Drugs used are atorvastatin at the dose of 40 to 80 mg at night time, rosuvastatin 20 to 40 mg at night time. Moderate intensity, we have atorvastatin 10 to 20 mg at night time, rosuvastatin 5 to 10 mg at night time, and simvastatin 20 to 40 mg at night time. The adverse effects of statins are myalgia, tendinitis, myopathy, rhabdomyolysis, hepatitis, impaired blood glucose, GI intolerance, memory impairment, confusion and disorientation. Antiplatelets therapy are warranted in patients who have a established cardiovascular event or the patients who are at higher risk for coronary artery events. We can use aspirin therapy 75 to 162 mg per day as a primary preventive strategy in patients who are at increased cardiovascular risk. Risk is assessed by ASCVD calculator. Aspirin therapy with 70 to 162 mg per day as a secondary preventive strategy in patients with diabetes and an established cardiovascular disease. If the patient has a documented aspirin allergy, clopidogrel 75 mg per day should be used. Dual antiplatelet therapy, that is low dose aspirin and a P2Y12 inhibitor such as clopidogrel, is reasonable for a year after a acute coronary syndrome and may have benefits beyond this period. After 1 year of ACS, clopidogrel may be discontinued and aspirin to be continued lifelong. Case scenario 1, we have a 50-year-old male, non-diabetic with a stable glycemic control and hypertensive for 5 years. He was admitted with acute coronary syndrome and underwent PCI 2 months back and came for follow-up. His BP was 130 by 80. His recent lipid profile was LDL cholesterol 170, triglycerides 151 and HDL 30 mg per deciliter. How to proceed? This patient has an established coronary artery disease. So, starting on high intensity statin therapy is appropriate. Secondary preventive measure, patient has to receive dual antiplatelet therapy. His final prescription would be tab atorvastatin 40 mg at night, tab aspirin 150 mg at lunchtime, tab clopidogrel 75 mg OD to be continued for 1 year. This is in addition to his regular treatment for diabetes and hypertension. His lipid profile has to be repeated after 4 weeks to look for the decrease in LDL cholesterol level. His LDL target would be less than 100 mg per deciliter. Lifestyle modifications to be continued, and in patients who are on chronic statin therapy, LFT to be monitored. Scenario 2, a 58-year-old obese female, non-diabetic for 7 years on OHS, came for follow-up in your PHC. Her recent lipid profile showed LDL cholesterol of 97 mg per deciliter, total cholesterol of 250 and HDL of 25. Her BP was 150 by 90 mm of mercury. No history of previous coronary artery disease, stroke, CKD or peripheral vascular disease. How to proceed? This patient does not have an established cardiovascular disease, but her 10-year ASCVD risk is more than 15. Hence, she should be at a higher risk for future cardiovascular events, and she would be a candidate for high intensity statin therapy and antiplatelet therapy as indicated as a primary preventive strategy. Advice would be tab atorvastatin 40 mg at night time and tab aspirin 75 mg OD. Clopidogrel may be given in case of intolerance to aspirin. Case scenario 3. A 52-year-old male, known diabetic for 10 years on OHS, came for follow-up in your PHC. His recent lipid profile showed an LDL cholesterol of 135 mg per deciliter. Other parameters were normal. His blood pressure was normal. He is a non-smoker. No history of previous CAD, stroke, CKD or peripheral vascular disease. How to proceed? This patient has an elevated LDL cholesterol, but he does not have an established CVD. Also, his ASCVD score shows a low risk for cardiovascular events. It is appropriate to start him on moderate intensity statins along with lifestyle modification. Antiplatelets may not be needed as the patient has lower overall CVD risk and does not have an established CVD. Advice would be tab atorvastatin 10 mg at night time and to recheck LDL levels after 4 weeks. Thank you.